Good evening, everyone, and thank you for joining us for tonight's session of the International Dermatology Education Foundation Educational Series webinar. My name is Ashley with RBC Consultants. As moderator tonight, we have Dr. Leon Kircik. He is President, International Dermatology Education Foundation, Clinical Professor of Dermatology at Icahn School of Medicine at Mount Sinai, New York, Indiana University Medical Center in Indianapolis, Indiana, Medical Director of Physician Skin Care, DermResearch, and Skin Sciences, all in Louisville, Kentucky. As speaker tonight, we have Dr. Andrew Blauvelt. He is board certified dermatologist, investigator, Oregon Medical Research Center from Portland, Oregon. The title of tonight's presentation is Step into Possibility, Explore Olumiant 2-year data. We would like to thank our supporter this evening, Lilly, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select cell phone or phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your questions in the question pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and it will also be emailed to you within 1 to 2 days. We would greatly appreciate it if you would fill out this very short survey. Within 1 to 2 days of the webinar, a certificate of attendance will also be emailed to you. Like we mentioned, questions can be submitted in the question pane on the right-hand side of your screen. Without further ado, I would like to pass the floor virtually to Dr. Kircik.
Thank you, Ashley, and good evening, everyone, and welcome to another series of IDEF. And I am back from Berlin, so greetings from Louisville, Kentucky. Despite Dr. Matt Zyrus's feelings, U.S. immigration let me back in. So tonight we're very lucky to have Dr. Blauvelt, and he's going to talk about Olumiant as well as alopecia areata. As you know, International Dermatology Education Foundation is a non-profit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. We have served in North America, South America. We have global educational series and webinars across Europe, Southeast Asia. And a couple of those, you can see the examples. Tonight, we are very, very lucky to hear from Dr. Andrew Blauvelt. He's a board-certified dermatologist and investigator, Oregon Medical Research Center. A good friend of mine. He is globally known, a good speaker, and a well-known thought leader in dermatology. So he's going to discuss Step into the Possibility, Explore Olumiant 2-year data. Thank you, Andy, and welcome. Take it over.
All right, thank you, Leon. I appreciate the introduction. I appreciate the invitation from the IDEF to speak with you all tonight. I'm going to speak to you about Olumiant for alopecia areata, and specifically kind of focus on the 2-year data, which is the latest data for this drug and for this disease. So we're talking about Olumiant, which is the brand name for baricitinib, which is FDA approved for adults with severe alopecia areata. And the title of the talk is Step into Possibility. So this is a talk that has to abide by promotional standards. That means that all the slides have been approved, been reviewed and approved by the FDA. And it means that the discussion will center on the product label for Olumiant. All right, so if you are interested in the details of the product label, this is the code for you to scan that you can actually pull up the label. You can do this at this time if you want to have it side by side as we, you know, on your cell phone, for example, if you want to look at the label while I'm speaking. It's also readily available online, right? So program disclosures, this is a program put together by Eli Lilly Corporation, and I'm presenting on behalf of Eli Lilly. So officially, I'm an employee of Eli Lilly for this talk. And again, it has to be in the standards of the FDA guidelines. In terms of addressing questions, we'll have time afterwards, I think, to address all your questions. Most of them should be related to the product insert, the label. I will probably refer most other questions to your MSLs, so your Lilly MSLs. And it's really important because in promotional talks, there's all kinds of information about these drugs that is not covered in the talks. So we have publications, we have earlier phase data, we have data that's been presented at meetings and recent meetings, including Berlin at the EADV. And so if you want the very latest information about Olumiant for alopecia areata, I suggest you talk to your MSL, who can provide you with that information. Right, so, but for tonight, we're going to hopefully become experts in the product label of Olumiant for alopecia areata and go over the basics, really the core data, both efficacy and safety for this drug for alopecia areata. So the indication, as I mentioned already, it's indicated for the treatment of adult patients with severe alopecia areata. So adults defined here as 18 and older. There's no upper age limit. And severe alopecia areata is not really defined. So it was defined in the clinical studies, and I'll talk about that in a few minutes. But for the product insert, for the product label, there's no definition given. So there is some cases, I think, of flexibility. If you have a patient in front of you who you deem to be severe, who, for example, may not have met criteria for the clinical study, it's possible, I think, that that patient could get a prescription for Olumiant. As far as limitations, like other JAK inhibitors, it's not recommended to use Olumiant with other biologic immunomodulators or systemic immune suppressants like cyclosporin or prednisone. So combination therapy is not suggested, not recommended. All right, we're going to go over an overview first of the disease and of the drug. Then we're going to do a deep dive into the clinical trial data from the BRAVE AA1 and the BRAVE AA2 clinical trials. And we're importantly going to talk about safety, an important issue for JAK inhibitors. And then we're going to talk briefly at the end just about getting started, how to get your patients going on Olumiant for their alopecia areata. All right, so right from the beginning, we're not going to hide it. We're going to just directly address the boxed warnings for Olumiant. These are fivefold. There's 5 boxed warnings. They are also the same boxed warnings that we find on all JAK inhibitors as a class. So all JAK inhibitors, oral and topical JAK inhibitors, have the same 5 boxed warnings. They are serious infections, mortality, malignancy, major adverse cardiovascular events, and thrombosis. So I'm actually going to tell you the origins of these labels and then also go into a deep dive of the actual Olumiant AA safety data and compare and contrast the boxed warnings and what they say versus the data that we see in the Olumiant trials. So the first thing you need to know is that that these labels, this label for Olumiant is derived from the JAK inhibitor Xeljanz, which is another JAK inhibitor that was studied in rheumatoid arthritis, so another disease, in patients over the age of 50, and in a study that looked at long-term safety of Xeljanz in that population. Those patients on average had about an age of 63, 64. They were also, many of them, most of them, on concomitant methotrexate and prednisone. So 3 drugs, Xeljanz, methotrexate, prednisone. And in that study, the Xeljanz group showed higher rates of serious infection, malignancy, major adverse cardiovascular events, and thrombosis compared to the TNF blocker comparison group. And that's the origin of these labels. So serious infections first. This includes active tuberculosis, invasive fungal infections. Basically, you want to check for TB beforehand. It's a requirement. And also monitor. So ask your patients about infection history. In particular, I focus on herpes zoster history and herpes simplex history. So JAK inhibitors can reactivate HSV and VZV. That's the focus that I place when I see this label on my patients. Of course, testing for TB. We look at mortality, again, referring to the Xeljanz study. It says in a large randomized post-marketing safety study in RA patients 50 years of age and older with at least one cardiovascular risk factor, comparing another JAK inhibitor, that's Xeljanz, to a tumor necrosis factor blocker, a higher rate of death was seen in the JAK inhibitor group. Slightly more cases in the JAK inhibitor group compared to the TNF blocker group. So that's the origin of that particular boxed warning. For malignancy, same referral to the same Xeljanz study. Lymphoma and other malignancies were observed at a higher rate in the JAK inhibitor group compared to the TNF blocker group. Major adverse cardiovascular events, the same sort of language here, referring to the Xeljanz study, and also just the general warning that more heart attacks were seen and more strokes were seen in that group in that particular study. And then the same language, again, same referral back to the Xeljanz language for thrombosis, DVT. So what do I use? How do I process that information? And so basically, I think it's you need to do a good past medical history. You need to do a good medication history, explore risk factors for cardiovascular disease, for DVT, record these and consider those items when looking at your patients who may be candidates for Olumiant who have alopecia areata. So one of the issues with these studies is many of those things in the Xeljanz study were in the older population, which tend to get those things in general. So it's one of the caveats in trying to take that data from the Xeljanz RA study and thinking about it for Olumiant AA. It's difficult, but you need to be aware of the box warnings, be aware of your patient's medical history, so you can intelligently manage your patients. But it is true that our patient population tends to be younger, tends to be healthier than rheumatoid arthritis, and we are using this drug as monotherapy and not as a concomitant therapy with methotrexate or prednisone. Okay, so we also have hypersensitivity in the label. That's a common thing for all drugs. We have GI perforations. We haven't really seen that in alopecia areata. That's, again, labeling that comes from the RA patients, where we have them, many of them are on non-steroidal anti-inflammatory drugs in combination with a JAK inhibitor. Okay. We do potentially see lab abnormalities with JAK inhibitors in general, and therefore it is recommended that we do blood test monitoring. Now, fortunately, I'm going to show you the numbers. The numbers are pretty low. This is a pretty a low thing to worry about, the actual low numbers for all of these things, but they can occur. So Olumiant can affect neutrophil count, lymphocyte count, red blood cell count, can increase liver enzymes as well, which I haven't mentioned, and increase lipids as well. So standard kind of translating that again into practice, I get not only a TB evaluation at the beginning, but a CBC with DIF, a Chem 20, which is going to have liver tests, and I get a lipid evaluation at baseline as well. And I periodically will monitor those. So there's no set time points recommended for monitoring. Most experts, most people who have experience with these drugs, like myself, will look at blood tests anywhere from every 3 months to every 6 months. That's just a non-label recommendation, although, as I mentioned, there isn't anything in the label as far as a set timing for blood test monitoring. All right, no live vaccinations. That's a common point in many of the drugs we use these days. And when we look at the most common adverse events, more than 1%, we saw UTIs, nausea, HSV, and HZV, or herpes zoster. So those were things that we saw most commonly. Fortunately, we did not see many of those boxed warnings, MACE, serious infections, malignancy, and so forth, and death more than 1% of the time. All right, let's see. There were also UTIs, there's acne can occur, hyperlipidemia is in there, CPK elevations, liver. So some of the other things that I mentioned are mentioned here as well. Oh, I'm sorry. The first ones I mentioned were in the RA trials, and then in the AA trials, it was UTI, headache, acne, hyperlipidemia, CPK elevation, UTI, liver enzyme elevation, folliculitis, fatigue, nausea, Candida infections, and a few other things there. Herpes zoster, weight increase. One thing I haven't mentioned yet, you should not get pregnant. Your patients should not get pregnant while on Olumiant or when they're breastfeeding. So this is not recommended for a patient of childbearing potential who is not using birth control. So you need to talk to your female patients about birth control if you are going to use Olumiant in those patients. It's not recommended either for patients with severe hepatic or renal impairment. Again, liver enzymes can go up, and it's excreted in the kidneys. So if you have severe renal dysfunction, you don't want to use Olumiant in those patients. Okay, I'm going to move on now to alopecia areata. So most of you watching know this disease. I don't know if you know how common it is. A lifetime risk of developing AA is 2.1%. That's pretty high. That's pretty high for any condition. Many people are going to be getting AA. Fortunately, the disease tends to be mild in most patients, but of course not always. And then it's highly unpredictable. It's really tough for us to know if someone is going to stay with a small spot or if they're going to progress on to full hair loss, either full scalp hair loss or full body hair loss. We don't have predictors of what patients are going to do. We don't have great treatments other than JAK inhibitors. And so this is just a little bit about the background for alopecia areata. It's non-scarring alopecia, usually not a difficult diagnosis, and of course, it can be a huge impact on patients' lives. You know, in my experience, anything beyond, oh gosh, 10, 20% for sure, the patients are really suffering. In the trials, just kind of fast forwarding a little bit, the requirement was 50% hair loss or more. Was the definition for entry into the trials. In my book, in my view, the word severe can be applied to patients with less percentage hair loss. There may be some pushback for you in payers. They might require that 50% number because that was used in the trials again, but it's not in the label having 50% or more. It just has the word severe. Okay. All right, so we're going to talk a little bit about how JAK inhibitors work. By now, hopefully, you guys have heard this. JAK inhibitors are now in dermatology for the last several years. You should have a basic understanding of how they work and how they're different than biologics. So we do know biologics. We've had biologics around for more than 20 years, and JAK inhibitors work differently than biologics. So here I'm showing cytokines shown in kind of a yellow-green on the outside of cells, and they bind to receptors in pink here that that they bind to make inflammation, basically to cause their effects. They have to bind their receptor on the surface of the cell. Now, cytokine receptors have an extracellular portion and an intracellular portion. And what happens when the cytokine binds to the receptor is that there's a conformational change in the cytokine receptor, and that inside portion actually changes its shape, and that change shape actually leads to activation of the JAK enzymes. So these are enzymes that phosphorylate things sitting on the inside of cells attached to the cytokine receptors. When JAKs are activated, they in turn activate a set of proteins called STATs. And then this JAK-STAT pathway dissociates from the cytokine receptor and goes to the nucleus. And STAT proteins cause gene transcription and more cytokines to be made. And we start the cycle again. So my analogy is a relay race. You have the baton being handed from one runner to a next. The first runner is the cytokine. The second runner is the receptor. The third runner is the JAK enzyme. The fourth is the STAT proteins. And the fifth runner is gene transcription in this relay race of inflammation. And the JAK inhibitors are blocking that third runner. So they're small molecules, and they are blocking, as shown here, on the inside of cell. So not only is Olumiant a oral medication that goes across the stomach into the bloodstream, it actually goes across the cell membrane as well and inside the cell and inhibits that activation of the JAK enzyme. Now, going back a little bit, how are JAK inhibitors different than biologics? Well, biologics tend to block one cytokine. With a monoclonal antibody on the outside of the cell, they're going to hit that first runner. Some biologics we have block the receptors, the second runner. But the JAKs are on the inside. And what happens is that different family of cytokines, in this case, gamma interferon, IL-2, IL-7, IL-15, and IL-21, this family of cytokines is inhibited by Olumiant because all of those cytokines utilize JAK1 as the third runner in their signal race, if you will. So the difference in biologics, again, tend to be blocking one or two cytokines. With Olumiant and other JAK inhibitors, they're blocking a family of cytokines, so a broader number, but they're different also, let's say, so more blockade than a biologic, but far less blockade than drugs that are pan-immunosuppressant, like cyclosporin or prednisone, which tend to push the whole immune system down. Okay, so it's a selective kind of family blocking of cytokines, and that's how we see their effects in immune-mediated diseases. Now, I think that's also why we tend to see more chances of side effects when we're blotting more broadly than if we're blocking a single cytokine. So this is the kind of the explanation of why we see really good efficacy with these drugs, but maybe a few safety issues because of that more broad blockade. Now, what do I tell patients? I don't go through any of this with my patients. I simply tell patients that Olumiant is an anti-inflammatory drug, but not like Motrin. So they know non-steroidal anti-inflammatories, they know Motrin, ibuprofen, and I say that, but technically this is a correct definition to call it an anti-inflammatory. It does decrease inflammation, these inflammatory mediators. So that's how I describe it, and they get it right away. They say, oh, a new type of anti-inflammatory drug. Okay, I'm ready to go. So pretty simple description for patients. All right, so here's that. We talked about that. All right, so who's a good patient? Basically, anybody with severe alopecia areata is going to be a candidate for this drug. Here we have an example, a patient with, anybody with over 50% hair loss for sure. They may have tried intralesional or topical therapies. They're distraught, over their hair loss. They want their hair back. I mean, this is a kind of a classic type patient that would be a candidate for this drug. Now we're going to go into the clinical trials. So as I mentioned already, technically that 50% number that I said is not exactly BSA. It's called the SALT score. And a SALT score of 100 means no hair, complete hair loss. And a SALT score of 0 means full head of hair. And patients had to have a SALT score of 50 or higher to get in, which is roughly about 50%. So it is that is what you should think of when you hear SALT score. It's another way of kind of saying what BSA is. Now, it's done in quadrants. You don't really need to know that. We measure the left, the right quadrant, the top, and the back to come up with our final number. Another thing that the trial did is that it took people that had to have 50 or more, but to be considered a success, you had to have a score of 20 or less, which it wasn't a percent improvement. So my examples are if somebody had a 51% hair loss, they got in the trial. And if they went down to 19, they were considered a success. So they had over 50 to start, they went under 20, success. But someone who had 100 to start and goes down to 21, 100 to 21 is considered not a success. Even though the percent improvement is way higher than that first example, the patient didn't get to 20 or less, so they would be considered a failure. It's a pretty tough criteria that the FDA has established for success or not success during the trial. Okay, that's important to know because I'm going to show you data about the people, the percentage of people who reached 20 or less. So remember that those analogies that I just mentioned for that. Okay, so the designs of both trials, they were similar, identical, placebo versus 2 milligrams of Olumiant versus 4 milligrams of Olumiant. It was blinded, and then we went to week 36. So 9 months, a possible placebo, 9 months at 2, 9 months at 4. We didn't know who was on what for 9 months. That was the first part of the study. And then again, the primary endpoint was how many people got to scores of 20 or less at week 36. That's the main endpoint, if you will, for the whole study, for both studies. And here we go. Here's the data. So we have the percent improvement on the y-axis. We have the week number going out to week 36 on the x-axis. And then we have the placebo in gray, and it's 3 to 5%. And then we have the 2 milligram dose, 17 to 22. And then we have the 4 milligram dose, 32 to 35% of people getting to that endpoint, which is pretty impressive given the severity of the start. You have to remember who was being treated in this trial. I didn't mention it, but people that have more than 50% hair loss, especially those with total hair loss, are particularly resistant to treatment and are a tough crowd, if you will. So this is the majority of the patients in the trial. And so you have to remember sort of it was a tough crowd. And we still got results like this, which I think are really impressive. This is the people who got 90% or more improved. They're basically they are near complete responders. So the people who did really, really well, it's 11 to 13% of patients on the 2 milligram dose and 24 to 26% on the 4 milligram dose. So clearly seeing a dose response here. The 4 milligrams doing better than the 2 milligrams in both of the things I've shown you now, both of the endpoints. Now, the really great thing about these studies, we're actually doing them and seeing for our eyes. Seeing was believing in my case. We're showing you some examples here. This is a patient at baseline who was 51, who actually just got in. She was on 2 milligrams, and she went all the way down to a 14. You can see significant improvement in her disease, going from a 51 to 14, is shown the left versus the right. Now here's an example of a patient who was on 4 milligrams, and he started at 100. He had complete scalp loss, was at 100, went on 4 milligrams, and very interesting, at 12 weeks, didn't have much to show for it. That middle panel, not much happening, but then look at the week 36 result. His SALT score goes all the way down to an 8, goes down to an 8. Really impressive result, and most of it coming in that second and third sort of 3-month block, sort of the last 2/3 of this portion of the trial was where the majority of the hair, when the majority of hair came back. All right, so this is also a really important slide. This is to give you context. When you're looking at the Olumiant clinical trial data, like I'm showing you, and if you're looking at the papers, this is actually the actual numbers of patients who had the different amounts of hair loss in the trial. And what you see is dominantly is that the majority of patients by far had 90 to 100% hair loss in these studies. 617 patients had almost complete or complete hair loss. The rest are kind of scattered in the percentages. The next biggest group is 50 to 55. It was 144 patients, but this really gives you, this really tells you directly, boldly, what kind of patients we were dealing with in the trial out of the 1,200 that I'm showing you. All right, now why is that important? So I showed you the overall data, looking at all comers, but this is broken down now. On the x-axis, what we have is the patients who had a baseline score of 50 to 94, and then the right-hand side is the people who had 95 to 100. And so let's first go to the left part. So the left part are the people, quote unquote, less severe, although you could say they all had severe, but let's say less severe. And what we see is that the percentages of improvement go up significantly if we take out those most severe patients. And what we see is 1/3 of patients now in the low dose, and almost half of the patients doing great on the higher dose when we take out that really tough group of the 95 to 100. And if we look over on the right, depending on how you look at it, we see 21% of patients with significant improvement on the 4 milligram dose. And this, again, historically would be your alopecia totalis patients, who historically would be really tough to treat. And here we're seeing a 21% excellent response rate in that crowd, in that population. It's also the basis. These data here are the basis for the recommendation. It's not hard and fast, but the recommendation to begin with 2 milligrams with quote unquote less severe alopecia areata, and to recommend starting 4 milligrams for the patients with totalis. So there is that recommendation. You can start on 2 or on 4. It doesn't really matter, but roughly based on these data, it gives you a little bit of guidance on which dose to start on which patient. Okay. So here's some more examples. Here is a patient at 50 to start with. At week 36, he goes to complete hair regrowth on 2 milligrams. So another example of a less severe patient at 50% at the beginning, and does 2 milligrams and has complete hair regrowth, doing really great. And then here's another example of the other way, 100 to start with, 100% hair loss, going on 4 milligrams, and having the score go all the way down to a 14. This is a success with 4 milligrams in a totalis patient. So some real life pictures, which again, doing the trials, it was incredible to see the patient's responses. All right, now what happens over time? So I showed you week 36 data, I'm showing you now for the first time week 52 data. And interestingly, the patients keep getting better. It's not dramatically big steps up, but from that week 36 to week 52, what we see is that the percentages tend to keep going up, keep creeping up. So these are people in orange who continually on 4, and then people in blue are continually on 2 milligrams. So more drug over time, you do see a slightly better response if you look at the total group, as shown here. All righty. So eyebrows. So we measured eyebrows. So very interesting, when we were doing the training for this trial, we were taught about the importance of eyebrows, and we're kind of shown pictures of famous people without their eyebrows, and we had trouble figuring out who the famous people were. And as soon as their eyebrows were put on, we could recognize them. So it was a pretty dramatic example of how important eyebrows are for our framing our face and for the cosmetic look of our face. We did see nice eyebrow growth. This is 4 milligram data I'm showing you here, and about a third of patients having really nice eyebrow regrowth on the 4 milligram dose. And again, this is something we tend to see also. This is for eyebrows and eyelashes, by the way. We tend to see this in the more severe scalp patients. So we tend to see eyebrow and eyelash loss in our totalis patients, but we can get regrowth in these areas as well. And here again with the 4 milligram dose. Here's some examples. We got a patient baseline with almost all eyelashes gone, and then full eyelashes on the bottom, and then on the right, no eyelashes to start with, and he goes to almost complete eyelash growth at week 36. These are not photoshopped. These are actual loss of eyebrows at the baseline, and then nice eyebrow regrowth, again at the 4 milligram dose I'm showing here at week 36. So it can make a dramatic difference for patients' faces. Excuse me. Oh, I needed a glass of water. Sorry about that. All right. Now, long-term extension study. So this gets a little bit complicated. The people who are on 2, they could go to placebo or they could stay on 2. The people who were on 4 originally could go on placebo, go down to 2, or stay on 4. So we wanted to get more data on what happens over time in people who were responders. Actually, I forgot to say that. All of these people that were put in different dose groups had to be responders to go into these different doses or to go off drug. All right. So what we see when people are taken off drug is that they tend to recur. And so the percentages of people who respond, if they start at 2 and they go to placebo, you see a drop in their response rate. And so now 90% of them basically lose their response. If they were on 4 and then goes to placebo, 80% of the people lose their response. So very, very clear examples that if you stop drug, you tend to lose response, and 80 to 90% of the time. That's the expected result if you stop Olumiant after you have had success. So unfortunately, the patients have to continue drug. Now, down titration, we sort of see a middle range here. So here are the responders who go from 4 milligrams to 2 milligrams, and about half of them lose response, and about half of them, though, are maintaining response. Okay, so it is possible to go from 4 milligrams to 2 milligrams in a subset of patients, and some patients will be able to maintain, others will not be able to maintain going from 4 to 2. So that's a simple answer. It's very clear. There's a dose response. 4 is better than 2. Tougher, stronger patients, if you will, you're going to need 4. Patients maybe not as severe, the 2. If you have a great response at 4, you can try going down to 2, but you don't have to. Perhaps some patients you'll be able to, and other patients will not be able to go from 4 to 2. Okay. How about the people who continued? So these are responders who stayed on their doses. And this is a really nice durability curve over time, over 2 years, from year 1 to year 2. So again, they had to be responders for this analysis. And if they responded to 2, 89% of them are still responding to 2 at the 2-year time point, and 91% of the 4 milligram people are still responding to 4 milligrams at the 2-year time point. So this is a really nice result compared to what I just showed you for maintenance of response in responders, highlighting the durability of this drug. All right. What happened when treatment dose was up titrated at week 52? So this is now people who may have been on 2 milligrams, right? And and were non-responders now. So non-responders on 2, some of them were put into the 4 milligram group. And what we see is that about a quarter of them you can capture. They become responders from going from 2 milligrams to 4 milligrams at the 1-year time point. All right, so lots of clinical data there, lots of, I think, really practical data, important data, I think, for your practices, and hopefully you found that useful to see that data. So now we're going to talk about safety. So we talked a lot about safety already. We're going to come back to it, and I'm just going to show you the numbers now in the Olumiant AA trials. So more than 5,000 patients have been treated with Olumiant over 9 years across 12 clinical trials. It is approved for rheumatoid arthritis and for alopecia areata. We just have lots of data on this drug, and I'm going to show you some of that data now. Now, first, if we look at placebo versus 2 versus 4, in the 36-week placebo control period, what we're seeing here, if we go back and forth between the placebo column, the 2 column, and the 4 column, you're looking for things that stick out, right? So UTIs occurred in pretty similar numbers, headache, pretty similar numbers. Acne, we see a little bit of a bump in the 2 and the 4 Olumiant group compared to the placebo group, from 2% up to about 6% of patients on Olumiant, and not much of a dose response. Hyperlipidemia, we talked about that. We see a little bit of that. It goes from 3% in placebo to about 6% in the high dose group. CPK, 1.3% placebo and 4.3% Olumiant. So small increases in CPK there. It tends not to be clinically relevant, so it's not emphasized in the label because we just see it, but we don't do much when we see a CPK elevated. UTI numbers, maybe a little bit of an increase there, 2.2 versus 3.8, 3.7 for Olumiant. Liver enzyme elevation, not much of a bump over placebo. Folliculitis, a tiny increase over placebo, 0.8 versus 1 to 2% in the Olumiant group, and then fatigue, about 1% placebo, about 2% with the high dose. So you're not seeing a ton of things here. A little bit of acne, right? A little bit of CPK elevations, but the nice news, the good news for us is you don't see much going on in the first 36 weeks compared to the placebo group. Now, let's look at some more things here. Here's UTIs. lower respiratory, not upper, but lower respiratory tract infections, we see a little bit of a bump from about 1% to 2% in placebo versus Olumiant groups. Nausea, not much of an increase there. Candida infections, maybe a little bump. Anemia, not much of a difference. It's 0.3 up to 1.3. Neutropenia, 0.8 to 1.3. Zoster in the first 9 months, 0.5% placebo, 1.4 and 0.9 in the Olumiant group. So slight increases, if you will. The good news for us is that everything on this list as well is occurring in low percentages. Okay, here's a little bit more on blood tests. The blood tests I mentioned, CBC with DIF, LFTs, lipids, and these are the percentage of patients that have more common numbers. And basically what we see is the lipids kind of sticking out here. So especially the HDL. So the HDL tends to go higher than the LDL, which is kind of interesting. You can see number, and it's pretty common. I don't really worry too much about the lipids either because of that, because the HDL tends to go higher than the LDL. But these are the numbers you see. Okay, now the really important stuff, the 5-box warnings, but now we're looking at data in the AA Olumiant trials. Okay, so here are the numbers. We have placebo rates generated over the first 36 weeks on the left-hand side, and then we have 2-year data sort of on the right, so we can compare the 36-week rate with the 2-year rate, and we can also kind of compare it with the placebo rate. And what we see is mostly good news here. We see mostly zeros for all of these things. We see a few cases of here and there. In the Olumiant group, there was, in the first 36 weeks, there was 1 case of MACE, 2 serious infections. There was 1 malignancy in the placebo group. If we go over time, over 2 years, we have 1 DVT, 1 MACE, 1 non-melanoma skin cancer. We have 2 serious infections in the 2 milligram, and we see 6 serious infections in the 4 milligram group, so a little bit of a bump there. Again, I think this is mostly good news because these rates are really low. All 5 of these things that we worry about a lot, that are the big box things, these are the actual 2-year data for Olumiant, again, in a healthier population than RA, and it's monotherapy. There's no other concomitant immunosuppressants. So this is the actual data that we see in the AA trials. Okay, now one of the things that is said and is mentioned is that, oh, we're seeing less of those things because we're in a healthy population, and maybe the drug still causes those things. So we cherry pick, if you will, clinical trial patients. Well, actually about 51% of the patients had at least 1 risk factor for one of the AEs of special interest. So over half of the patients had some risk factors in the trial for some of these things, including BMI, smoking, hypertension, low HDL, diabetes, history of malignancy, more than 65 years old. So it wasn't necessarily a pristine population. They weren't necessarily cherry picked. All right. So here is sort of the risk, the numbers breaking down with no risk factors beforehand versus some risk factors. And you see actually a few more cases in people who had risk factors for those things versus if they didn't have any risk factors to start with, then there's rare cases for any of these 5 issues. All right, so that's the safety discussion. Again, I think it's honest. It tells you where the box warnings come from. You need to know that. And you also need to know what the actual data is in Olumiant with AA patients. And that's 2-year data. And that's going to be important to follow, right? We're going to be following that for years now. So every year we're going to have an update of that safety data. Right, getting started. Again, we kind of talked a lot about this already, 2 versus 4. There's actually 1 milligram tablets as well. I do recommend for people with more severe alopecia areata totalis, people with eyebrow or eyelash loss, I do recommend the 4 milligram dose. For other folks, you can start at 2 and often have good success. We talked about this a lot, TB screening, hepatitis screening, we didn't mention that, but it can cause liver disease, right? So you kind of want to know that as well. CBCs, lipids, yeah, we talked about this quite a bit. All right, so Eli Lilly has great programs. So I don't expect you to memorize this slide. Just know that Eli Lilly has great programs. We have an experience with Taltz with them. The same pretty much programs apply with Olumiant. If your patient has commercial health insurance, especially, you should be able to get Olumiant and put your reps to work on this. So let them help you, help your office get your patients started. Don't try to figure it out yourself. Just get your Lilly rep in, ask them to give you the simplest possible ways to fill out the paperwork, simplest possible ways for your patients to get on drug. All right, there's savings cards, there's all kinds of rebates and things, so definitely recommend it. So in summary, I showed you meaningful hair regrowth in a tough population. I showed you sustained responses over 2 years. I demonstrated the safety profile extensively, talked about all the possible side effects, showed you the actual numbers, gave you context of the label, kind of where it came from, important information for you to know when talking about this drug with your patients. So with that, I'm going to stop, and I think we've got about 10 minutes, and kick it back to Leon to lead the question and answer period. Thank you.
Andy, thank you so much for that great lecture. I learned a lot. I always learn something from you, so I appreciate it. And we have a lot of questions. I'm going to try to get to all of them in the last 10 minutes we have. So one is really, and I think this is a really good question because we have flexible dosing, right? 2 milligram to 4 milligram back and forth. So when do you decide to go from 2 to 4? And I heard you saying about severe patients, but how much time do you give for the 2 milligram to work?
Yeah, it's a really good question, and there isn't really anything in the label about that. So because the trial design, as I mentioned, was week 52 before any kind of changes were allowed. But in practice, I usually tell people 3 months. And I know I showed an example where not much was happening at 3 months, but I think that was the 4 milligram example. What I didn't show, if the patient's on 2 and they've got nothing at 3 months, I would go to 4 at that point. I wouldn't wait longer. Another thing that comes up is how long, right, to go. Like that's not in the label either. What if you're a patient on 4 milligrams for 6 months? This is a common question. Do you keep going or do you stop after 6 months? I say keep going, because there are examples of people that pick up in that second 6 months. And so I personally would recommend going a full year on 4 milligrams before stopping and saying failure. I know that seems like a long time. It's a long time, right, for us in dermatology, but I think it's appropriate for this kind of drug and this kind of disease.
So, interestingly, we're learning now to be a little bit more patient because with psoriasis, with AD, right, it's 12 weeks, 16 weeks, the tops. But we know now with vitiligo and alopecia areata, I think we have to be a little bit more patient, go to 6 months, even to a year. I agree with you that those are really tough issues and it takes a long time to see those results. And most of those patients are desperate, so I think they will be willing to wait because until now we didn't have anything else, right? So the question is the reverse question. Somebody is doing well on 4 milligram. Do you attempt to go up to 2 or don't rock the boat?
You know what? I'm okay. I'm okay with going from 4 to 2 if you want to try. because we do know we see a little bit of dose response, right, in the AEs. It's not like a huge increase
Right.
that we see all kinds of issues with 4 that we don't see in 2. What we see is little bumps, right? We see a little bit more of kind of zoster. We see a little bit more of HSV. We see a little bit more lipids when we are at 4. So yeah, I think it's probably because of that. I think it's probably worth it to explore 4 down to 2 in some patients with caution, but I would kind of watch them closer. I probably would watch, if I'm doing that, I might watch them once a month or at least every 2 months, because I don't want them to go too far, right? I don't want them to start like I would explore and then watch closely in the right population. But if somebody says, I don't want to go there, I don't want to go there, I don't care if I got, a little higher risk of things, then I probably wouldn't push them to go down.
I'm gonna apologize. I missed it if you talk about it, and I wasn't involved with this clinical study, so I wasn't sure. Was there a randomized withdrawal period with this study or not?
Yes.
There was. So
yes.
How long did it take for the disease to come back when they get off the drug?
Yeah, I showed that. So at the week 52 time point, the responders were either kept on their dose or some were put on placebo. And the people who were on 2, the responders on 2 were put on placebo, 90% of them lost their response. So
How long did it take,
and
though?
it comes down pretty quick.
It's quick.
Yeah.
Okay.
Within a few months, you see the hair being lost again.
So I guess it's a clear message to keep for us to keep the patients on the drug.
I think it is, but there is some people that you are going to be able to go from 4 to 2. There's going to be some people that you're going to be able to get away with that.
Great, good to know. Now, I think you really did a great job in the beginning when you went over the black box warning and all where it comes from, the history. But if you can put a little bit into more context about that whole safety information, the whole the box warning when it relates to the general population, rather than, if you can, rather than talking about the RA population, that where the box warning really comes from.
Yeah, it's a really good question and it comes up a lot. So people ask me, well, what are those numbers you just showed me? The 0.3, 0.4 events per 100 patient year. What does that mean? So in general, we want to see rare events like that at 0.5 or less in a clinical trial, because the community or background rate is going to be anywhere from 0.3 to 0.5 for cancer and for heart attack. And so to give some context, the rate that we're seeing in these trials of those things is consistent with that background rate that I just quoted. So it is important to kind of know context of, is it a higher rate than normal? It doesn't look like it. Of course, it is an indirect comparison, right? So we didn't do that in the same study, but historically we can look at those numbers and how they compare to community rates.
Great. We're don't have much time, but as you are always a great speaker and you attract a lot of people and a lot of questions. So I'm just gonna go on, and whoever wants to hang up, they can hang up. So do you think Olumiant is worth trying for an adult patient with long-standing alopecia universalis?
Yes. The short answer is yes, but it is a good question. And I did not emphasize it because for years and years, Xeljanz was used off-label, right? It was used off-label by dermatologists if they could get it for alopecia areata. And one of the things we learned from those years of off-label use is that people that had more long-standing disease tended to do more poorly with Xeljanz. So this is before Olumiant, and so the clinical trial criteria, I think was eight years. I think they couldn't have had disease episode lasting longer than 8 years. I may be wrong, and then it may have been 6 or 7. I think it's 8, but basically there was a limit put in the trial design to try to not take those people. But there's nothing magical about the 8-year number, right? There's always going to be examples. So, I mean, if I had alopecia areata for 15 years,
Yeah,
I would try it. I would try it. I think you never know, but it is true that the longer, let's say beyond 10 years, it is true the longer you have it, the less likely you are to respond.
So the other one is really, we sort of answered it, but how long can this medication be taken for?
It's a good question. Indefinite is the answer. Of course, we don't have an answer, a firm answer, right? So we see lots of indications now. You know, I still see people in dermatology who are reticent to use these drugs, and I'm telling them, look, you kind of should get over it because they were all up and in dermatology. So, you know, not only alopecia areata, but atopic dermatitis, vitiligo, studies now in HS, studies in lichen planus. I mean, we are going to see more and more JAK inhibitors in dermatology, and for things that we don't have great alternatives. And so I just, it's a little bit, it's not really answering your question, but I do think dermatologists need to get comfortable with these drugs, and we'll probably learn these things over time. Of course, we're going to have long-term safety data with them and real-world safety data, which is going to be important. And it's going to be important to collect all of that. But I don't know. I'm not too worried about it, Leon, because, you know, I think TNF blockers started with boxed warnings.
I remember that.
Serious infections and lymphoma, boxed warnings for TNF blockers. And we kind of know, you know, over time, over many, many years of TNF blockers, the rate doesn't go through the roof. So I really don't think we're all of a sudden going to see rates of cancer or heart attack, you know, all of a sudden, you know, after 5 or 10 years of use, things going through the ceiling. I just don't think that's going to happen. And I think we'll see, you know, low numbers and hopefully low numbers over time.
You know, ironically, most of the box warning in TNF alpha inhibitors came from the RA population too.
That's correct.
So,
that's correct.
Can patients with diabetes mellitus and thyroid disease take Olumiant?
Yes.
Also,
no issues.
Right,
unless there's severe renal disease.
Also, do heavier patients need 4 milligram and lower weight patients need 2 milligram dosage? So this is a question that we always ask in psoriasis, right?
I don't know the answer to that, and I don't think I present it. There's probably an answer to that. There have probably been a sub-analysis done. I'm sure there has, but that's a good question for the MSL. The MSL.
Yeah, I have not known that. I have not heard, at least I don't know. Can you also do intralesional canalox when patients are on Olumiant? So that's going to be off-label, maybe.
Per label, no. So per label, it's not to be used in combination. So if one chooses to do that, it would be considered off-label, but you just need to know that it would be considered not on label.
In your experience, have you actually seen an increase in UTIs? That's really your experience they're asking.
No, in my experience, I've been using JAK inhibitors now in trials for about 6 years, Leon. 6 years of JAK inhibitor use, large numbers, lots of different diseases. And, you know, we don't see a whole lot. we look for it, we look for things, but we're not, in my personal experience, I don't see a lot of AEs in general with JAK inhibitors. Occasionally here and there something, but yeah, pretty much to me, they've been really safe in my hands.
So let's finalize this great conversation with, if you can give me 1 or 2 key takeaways that will highlight what we discussed tonight, what we talked tonight for the participants.
That's a good question. One is be a user. Don't be a non-user. I really, I've alluded to it, but I'm going to say it stronger now, Leon. If you are a dermatologist and you have a patient with severe alopecia areata and you don't prescribe a JAK inhibitor and you go with prednisone, or, I mean, that is not good. To me, that is not good. That is not practicing sort of gold standard of care for your patient. We now have, an FDA approved drug for this disease with really nice data. So number one, be a user in the appropriate setting with the appropriate patient. Don't let that patient walk away from your office without giving them what they need and really what has been proven now to be safe and effective. So be a user. And then secondly, don't be afraid of the label, safety, know where it came from, and then know what the actual data is in the trial, which I went over in detail tonight. So I don't want people to just look at the label and say, oh, no, not gonna go there. That's the second major message. Don't do a knee jerk on the black box labels for JAK inhibitors. Actually understand it and be able to then move on from it.
Great. 2 key aways, take key points, and I appreciate you being here tonight. And thank you very much, everyone. And I also want to thank one more time to our supporter, Lily, for making this possible tonight. Thank you, everyone, and good night for hanging us with us. Next week, we have a great program with Dr. Ted Lane. So it will be a targeted approach to non-segmental vitiligo treatment. So please join us again. Good night, everyone. Bye-bye.
Thank you.